We did part one of AKI a few days back, and today's part would be a rehash of the same, probably pertaining to the important questions which you may be, getting in the exams pertaining to ED. So I'll just try to put it in certain case vignettes and try to make you understand that. So this was the case vignette. You had a 72-year-old woman with a history of hypertension and heart failure who presents to the emergency department with fatigue, giddiness, and decreased urine output for 2 days. Now she had an episode of viral gastroenteritis with multiple episodes of diarrhea and poor oral intake. So we did a physical exam and the findings were as follows. BP of 95 by 60, heart rate of 110 beats per minute, dry mucous membranes, decreased skin turgor, and no peripheral edema. Labs were BUN of 45, creatinine of 2.1, urine sodium was increased, 10 milliequivalent per liter. FeNA, or the fractional excretion of sodium, was 0.5%. Urine analysis did not show any protein or any casts. So the diagnosis is fairly straightforward. It's a pre-renal AKI. Now, what we need to know in this, or what may be asked out of this, are the diagnostic and definition cutoffs. Now, we've done all the three criteria, rifle, Akeen, as well as the KDIGO criteria. Now, in the past class, and the KDIGO criteria is the one which is supposed to be the most valid. In the past class, I also covered that we need to know about when to intervene in oliguria, how is it important, and about the prognosis of an oliguric patient, stating very clearly that whether a patient, if he or she is oliguric, whether they have a better prognosis, when are they expected to open up, and accordingly. We also need to do a prognostication between oliguric vis-a-vis non-oliguric subsets. Then you have certain scoring systems for AKI. Again, the same thing. So how do you intend to use them and how do you intend to move forward in them? And also be able to elucidate the broad principles of treatment. Now, what are the broad principles of treatment? Is there any doubt? Okay. So basically, most of the times the broad principles of treatment would be hydration. Hydration would be appropriate hydration. When we did it in the class, it was very clear that when we talk about appropriate hydration, volume overload is also detrimental. And actually, this gives rise to bad outcomes. So an appropriate volume resuscitation, maintaining a good pressure head, and thirdly, of course, avoidance of nephrotoxic medications. So whenever we talk in terms of AKI management, the broad principles of treatment would remain the same. There's the second vignette. You have a 60-year-old man, type 2 diabetes and hypertension, who is admitted to the ICU with septic shock because of pneumonia. Now, this guy was started on broad spectrum antibiotics and he required vasopressor support. Examination findings, BP of 80 by 50 mm of mercury, tachycardic, heart rate of 115 beats per minute, cool extremities, as well as decreased urine output or oliguria. So when we go through the labs for this particular patient, BUN of 50 milligram per deciliter, creatinine of 3.4, baseline was 1.1 milligram per deciliter. Urine sodium was increased to the tune of 50 milliequivalent per liter. FeNA, or the fractional excretion of sodium, was increased to the tune of 3%. Urine analysis showed muddy brown casts. So quite clear, it is most likely a septic ATN or probably acute tubular necrosis secondary to sepsis. So this is basically the intrinsic AKI or the renal type of AKI. So now here we need to know about the potential pitfalls of serum creatinine values. They were discussed earlier in the earlier class. And we need to know when to use our serum creatinine values, what are the caveats, what are the true and false values, and how you need to interpret it with caution. Plus, serum creatinine levels will never give you a timeline of the renal insult, so that also needs to be ascertained and that also needs to be emphasized. We need to know the timelines for cortical necrosis, when it is bound to happen, and when you would get a cortical necrosis, especially on imaging. We also need to know what are the current concepts in terms of avoiding volume loading, identifying new means of fluid resuscitation endpoints. Now, I'm not too emphasizing too much on that because there would be a hemodynamic monitoring module in which you would cover it about how you would actually be doing the newer modes or the newer means of what would be your fluid resuscitation endpoints and how would you actually assess volume responsiveness in current context. Of course, another one would be choice of IV fluids, which you would use, where you would use normal saline, where you would use ringer lactate, which we covered, and where all would you use balanced fluids if feasible. Then what is the value of urinary sediment? Of course, when you would see a clear sediment, when you would see a muddy brown sediment, or when you would see certain other things and how important are they? So this is all that needs to be covered. And of course, urinary sodium and fractional excretion of urea. Why it becomes important is because certain of these patients may be having, lactic acidosis, or these patients may be on diuretics. So in these patients, FENA may not be that accurate. And in those patients, you have to talk about fractional excretion of urea. So these would be the discussion points for a intrinsic AKI. So when it comes to differentiation, this is a broad one, but basically just to remember, I put a slide. We've discussed it in the main class of acute kidney injury. So this is pre-renal, wherein you had dehydration, heart failure, also known as cardiorenal syndrome, liver failure, also known as hepatorenal syndrome. Of course, intrarenal causes, namely intrinsic renovascular disease in the form of hypertensive emergency, small vessel vasculitis, thrombotic thrombocytopenic purpura or hemolytic uremic syndrome, then glomerular disease in the form of post-infectious glomerulonephritis, then tubular interstitial disease in the form of acute tubular necrosis and acute interstitial nephritis. This acute tubular necrosis would be mainly seen in sepsis. Sepsis is the most common cause when it comes to ICU. And all of the other things, medications, some certain nephrotoxic medications, then contrast-induced injuries, if any, rhabdomyolysis, or maybe a prolonged pre-renal AKI, which has actually progressed onto intrarenal AKI. Post-renal causes obstruction, mechanical obstruction. So either it would be a ureteral obstruction, neurogenic bladder, then there can be a urinary tract infection because of retention of urine. Then there may be certain medications in terms of certain irrigations that are used. And of course, benign prostatic hypertrophy. Little word about NGAL, we need to know. It's a biomarker and it can be positive in AKI, chronic kidney disease, patients of stroke. These are false positives, heart failure along with CKD. You need to know the measurement specifics, how much time it takes, and when do you expect it to be of value to you. Most of the times, it is a cardiac surgery specific scoring, wherein the cardiac surgery subsets are the one which actually benefit most by using NGAL. We discussed this before last time, and we need to know the biomarkers in that context. This is the cardiac surgery associated acute kidney tubular damage, and this is the score at which you think in terms of tubular damage. Cardiac surgery associated NGAL score, that's what it's called as. So 0 is tubular damage, where it is unlikely. Then 1, you have a possible tubular damage. 2, you have a tubular damage. And third is, of course, a severe tubular damage. So how to put everything together for diagnosing acute kidney injury? Um, you need to put together all these things. You need to know about these. You need to talk about serum creatinines, and what are the pitfalls and shortcomings. You need to talk about urine output, how it is insensitive to certain forms of AKI and may not be reliably measured. Then serum cystatin C, which has a similar profile to creatinine. Then again, urine sediment, which can help identify extremely specific causes. But the problem that happens is that it is not standardized. Then certain kidney damage markers, UKIM1, UNGAL, others, then risk markers, which are again difficult to talk about whether how much value and how much validation they carry, but nevertheless they need to be known. And then you have got functional stress tests, which examine the capacity for increase in function by stressing the system. These tests are again not well standardized. We've got a furosemide stress test, which we will be doing subsequently again. It was told last time, and a protein load test. This is mainly for patients who are going from AKI stage 3 and beyond. So all these things would be something that you would need to put together and talk about. Certain images may come. Specifically, this is pyelonephritis, which is what we are talking about, an infected kidney and a healthy kidney. You can see both encircled. And this may be the one of the more commoner images that may come to you. Of course, a Staghorn calculi may also come, which is what this, wait a minute, I just try to put it on the marker. Okay. So this is classically a Staghorn calculi that you can see here. You know. And these are the infected kidneys. If you see, this is the right kidney, which is infected and has pyelonephritis in it. Then we need to know about the resistive index, USG findings, about how resistive index needs to be interpreted. What are the renal determinants and what are the extrarenal determinants? And if you have an increased renal resistive index, what all does it indicate? Arteriosclerosis, tubulointerstitial disease, end-stage renal disease, a very, decreased capillary arterial cross-sectional areas, and of course, increased renal resistive index to the tune of the cutoff is more than zero point 0.7. This is again something we discussed, but this is slightly more in detail and with the images. Then we need to know the timelines for recovery from acute kidney injury. So there is some literature on that, which is there within, I don't know whether you subscribe to the PAC modules or not, but it is there in that recovery within 48 hours of AKI onset is termed rapid reversal of AKI. If you've got a failure to recover at 48 hours, it is called as persistent acute kidney injury. And if there's a failure to recover at day 7, it is called now as acute kidney disease. So remember that term. Day 7, you've got acute kidney disease, whereas within 48 hours, it is always AKI. Now, if acute kidney injury or acute kidney disease, it persists for more than 90 days, then you can make a diagnosis of chronic kidney disease or end-stage kidney disease, which is defined by, if it's a chronic kidney disease, it is defined by GFR of less than 16 mils per minute per square meter of body surface area. Whereas for end-stage kidney disease, the same cutoff is less than 15 mils per minute per square meter of body surface area, which can be made. When do you use CT MRI? Non-contrast CT is gold standard. Remember that for urolithiasis and pyelonephritis. If you're doing a triphasic CT, it can actually allow for assessment of GFR and renal blood flow simultaneously. MRI currently has no role in diagnostic workup, initial diagnostic workup. And indications of biopsy will include persistent loss of kidney function or a proteinuria which is persistent and becomes more than 3 grams per day. Furosemide stress test. This is a slide from the first class itself. How do you use it to guide resuscitation? So if it's a furosemide naive patient, I'll just put the mouse again. Okay, yeah. So if it's a furosemide naive patient, this patient would require 1 milligram per kg IV bolus. If the patient is not furosemide naive, that is, this patient has received furosemide earlier, then you need to give a 1.5 milligram per kg IV bolus. So the urine output would be more than 200 ml in 2 hours. Then the patient is deemed to have passed the furosemide stress test, and it's more likely to be a pre-renal oliguria. Then you replace the urine output in these patients, attempt further hemodynamic manipulation, and here urine output may be a useful measurement of organ perfusion. If the urine output is less than 200 ml in 2 hours, then the patient is deemed to have failed the furosemide stress test. Patient is deemed to have an intrinsic renal failure. Additional fluid, vasopressors, or inotropes are unlikely to improve urine output. And here, urine output may not be a very meaningful measurement of perfusion. One question that might be asked would be when you would actually, time your RRT or time your renal replacement therapy. So again, you've got various tests. You've got Akiki 1, you've got Elaine trial, you've got Ideal ICU and Start AKI, Akiki 2, many trials. But just one line to remember that no major benefits have been derived from early renal replacement therapy. Different trials have been done, but the situation remains the same. Then there are other markers. Just a bit about markers that you need to know. Cystatin C, of course, you need to cover that. We covered that in an earlier slide about how it's similar to serum creatinine. Then you've got tubular stress proteins, tubular stress biomarkers, you've got tubular damage biomarkers, as well as tubular inflammation biomarkers. So actually what you are looking for is a functional amalgamation of all these markers together. But till date, no major validation has happened. NGAL has been good for cardiac surgery subsets, but again, not great work in so many other subsets. So then you also need to know when it comes to recovery of acute kidney injury, how would you actually phase it out? You've got patients in whom serum creatinine returned to baseline concentration, absolutely. They would be classified as subclass 0A. Subclass 0B would be defined by a return to baseline serum creatinine concentration, but with evidence of ongoing damage, injury, or loss of renal glomerular or tubular reserve, whereas subclass 0C would be defined by a serum creatinine level which is less than 1.5 times of baseline, but it is not back to baseline. I'm just putting in a classic slide about cardiorenal syndrome because you need to know about how is it different from each other. So cardiorenal syndrome type 1 would be basically a sharp decline in cardiac function, which would actually lead to acute kidney injury. Cardiorenal syndrome type 2 would be a chronic cardiac dysfunction, which could actually cause chronic kidney disease. Whereas type 3 would be an acute kidney injury, which would actually lead to acute reduction of cardiac function. Type 4 would be a chronic kidney disease that would lead to chronic cardiac dysfunction. This is precisely the opposite of type 2. Remember that, type 4 is opposite of type 2. So do remember that. And again, when you look at it, type 1 and type 3, they seem to be running opposite of each other. Type 5 is entirely different. Type 5 is basically a systemic disease. It could be lupus, it could be something else that can cause both cardiac and kidney dysfunction simultaneously. Thank you. I think this is enough for this thing.